Okay, good evening, good afternoon, good morning, whenever you're watching this, dear colleagues. My name is Andrei Varvinskiy. I'm consultant anesthetist at Tobay Hospital in the United Kingdom. My interests include difficult airway management, education, and also regional anesthesia. Today, the topic of my presentation is basic principles of regional anesthesia. We are going to talk about several topics today. We will start with pharmacology of modern local anesthetics. We will continue with local anesthetic systemic toxicity. We will then speak a lot about principles of performing regional anesthesia under ultrasound guidance. Then we will discuss the regional anesthesia and compartment syndrome, and we will finish with good rules of regional anesthesia. But first, a little bit about history of local anesthetics, and it starts in 1956 when Albert Niemann of Göttingen, Germany, isolated an alkaloid from dried leaves and named the active ingredient cocaine. But it's not until Vasily von Anrep, who was to draw the attention to cocaine's ability to produce local anesthetic effects, and it's him who proposed the use of local anesthesia during surgical procedures. And then it was a very famous Dr. Sigmund Freud who took a special interest in cocaine, noticed the cocaine's ability to cause numbness on the tongue, shared this knowledge with Karl Köhler, who was interested in providing local anesthesia for eye surgery, and it was him who introduced cocaine drops into the eyes for extracting cataracts. But not until 1904, when Alfred Einhorn synthesized procaine, which was known under the commercial name as Novocaine, new cocaine, when the real era of local anesthesia began. As from 1906, it started to be produced by the Hearst Company in Germany, and it's still used up until the modern days. Well, let's talk about pharmacology of modern anesthetic agents. The pharmacology of these agents. We'll speak about the structure of the local anesthetic molecule first. And the structure is in three parts. And the first part is the aromatic part on the left side of your screen, which is also a lipophilic part. And on the right side of the screen is the amino group, which is the hydrophobic part. And in the middle, they are connected with the intermediate chain. And it's by this intermediate chain that we divide all the local anesthetic into the two main groups. They're either esters, amino esters, or amides, amino amines. And among esters, we count very famous cocaine, benzocaine, procaine, novocaine, tetrocaine, and chloroprocaine. And if you think they're not used anymore, they are, because procaine is still being used in many countries, and tetracaine certainly being used in ophthalmic anesthesia, and chloroprocaine is now being used in spinal anesthesia. And amide groups is bigger and larger, and it's lidocaine, famous lidocaine, prilocaine, bupivacaine, ropivacaine, levobupivacaine. That is used in many countries across the world under different commercial names. Let's talk about main properties of local anesthetic. And we are anesthetics, and we are interested in three main properties of local anesthetics. We want to know how quick is the local anesthetic begins to work, what is the speed of onset, and that speed of onset is determined by this constant called pKa. And the also, which we'll speak about later a little bit in more details. The second property is potency, and potency is determined by fat solubility, and it's been agreed that the potency of procaine is 1. In comparison, bupivacaine is 16 times more potent than procaine, and there are lots of them in between. And then we're interested in duration of action, which is determined by the ability of the local anesthetic to bind to blood proteins. The more they bind to blood proteins, the longer the local anesthetic works. Okay, let's talk about speed of onset a little bit more. And I have to tell you that in solution, local anesthetics presented in two forms. Um, the alkaline non-ionized form and the ionized cationic form. And the pKa is the pH of the solution where these forms are in equilibrium, i.e., 50% of the solution is in non-ionized form and 50% is in unionized form. The lower the pKa, the faster the onset, because only the B form, the non-ionized form, can go through the membranes. So if the pH and if the pKa shifts down, becomes more acidic, the more alkaline, the more non-ionized form is present in in more alkaline medium. The more of the non-ionized form present, the quicker the onset of local anesthetic. And if you can look at the graph here, which shows the relationship between the pKa and the speed of onset, then you can notice that lidocaine has the lowest pKa, hence it works a lot faster than, for example, bupivacaine, tetracaine, and chloroprocaine. So why do local anesthetics perform poorly in the infected tissues? For exactly the same reason. Because in infection, the tissues become acidic, pH drops before 7.4, and less of non-ionized form is present in the solution. So the onset of action is prolonged. So you might want to inject into you don't really want to inject into the infected tissues because it's not going to work as well as. Plus, the faster elimination due to more abundant blood supply takes the anesthetic out of the tissues. So, if you really want to use local anesthetic for abscesses, you need to inject into the healthy tissues around this infective area. What else we can do to increase the speed of onset? We can alkalize local anesthetic. We can add sodium bicarbonate into it. So by doing that, we're increasing the pH of local anesthetic solution. That increases the amount of non-ionized form, resulting in an increase of the rate of diffusion of molecules through the nerve sheath and nerve membrane. Um, it also slightly reduces the pain on injection and definitely increases the speed of onset of anesthesia. Hence, there are many different solutions. One known for obstetric anesthesia, something called Rochan solution, where local anesthetic is mixed with sodium bicarbonate and also added adrenaline. So the doses of sodium bicarbonate, 8.4% sodium bicarbonate, are slightly different. So if you're using lidocaine, 1 or 2%, you only need to add 2 mils of sodium bicarbonate. Or if you're using bupivacaine, you only need to use 0.1 mil per 20 mils of the bupivacaine or ropivacaine. Because if you add too much, then you are facing the risk of precipitation. So the solution will precipitate and you won't be able to use it. So be careful if you are to use sodium bicarbonate with local anesthetics. Local anesthetic potency, as we said, depends on lipid solubility. And let's have a look. Here's the lipid solubility of procaine, says 100. And procaine, as we said, is 1, the potency of 1. And if we look at the high potent agents like tetracaine, bupivacaine, and atidocane, it's a lot higher. They are a lot more lipophilic or hydrophobic, which is the same thing. Hence, they are a lot more potent. Duration of action, as we said, is determined by protein binding. And let's have a look again. Protein binding of lidocaine is only 65%. Hence, the duration of action is anything between 60 to 190 minutes, depending on where you inject it. But bupivacaine is 95% protein binded. Hence, the duration of action, again, depending on where you inject it, can last up to 440 minutes, a lot longer. and then compared to lidocaine. I'm not going to compare everything. I'm just comparing the most widespread types of local anesthetics. Let's talk a little bit about the mechanism of action of local anesthetics. I'm just going to remind you how it works. We already spoken about the non-ionized form and ionized form. On this slide, they call slightly different unionized and ionized. So unionized form or non-ionized form goes in. It then combines with hydrogen ion and becomes ionized, and it's this ionized form that goes underneath the sodium channel and goes into the sodium channel and blocks the voltage gated sodium channels. So there is no propagation of the nerve impulse from that tissue. That's how the local anesthetic works. Hydrophobic delivers the local anesthetic to the receptor, while the ionized form blocks the sodium channel, first reacting with hydrogen ion. But it's not the only mechanism of action of local anesthetic. It also blocks other channels like potassium channel, like calcium channels, sodium potassium ATPase channels. Hence, it blocks the ATPase production, but also blocks the ryanogen receptor. All this is important in terms of other actions of local anesthetic and side effects of local anesthetics. Okay, let's talk about what happens to local anesthetic when we inject it into the body, around the axon of the nerve, for example. There will be non-specific local tissue binding. Then the local anesthetic will be absorbed into the bloodstream, and it's from the bloodstream that, depending on the metabolism, they either be metabolized by plasma cholinesterases, or they will go into the liver flow, by flow portal circulation into the liver, and liver will be metabolizing it using the normal P450 cytochromes, and then they will be excreted by kidneys. But from bloodstream, a local anesthetic will also be carried into the brain, into the heart, into the systemic tissues. Hence, if the dose is increased, then it could be the case of local anesthetic CNS and cardiovascular toxicity, which we will discuss later on. Absorption, they're very rapidly absorbed from the tissues. At low concentrations, they usually vasodilate. Adrenaline, of course, reduces the absorption. We'll speak about that a little bit more. And high binding to tissues proteins also reduces the rate of absorption. And depending where do you inject it, the systemic concentration could be lower in case of subcutaneous injections, or really high, classically if you inject it into the intercostal area, and many other in between. Okay, so intercostal, highest absorption, subcutaneous, the lowest absorption. Okay, metabolism is different between amino esters and amino amides. With amino esters, they are hydrolyzed by plasma esterases, except cocaine, which is metabolized in the liver by carboxyesterase, a different enzyme. And one of the amino ester metabolized para-aminobenzoic acid, PABA, may cause allergic reaction in itself in susceptible individuals. And rapid hydrolysis leads to a very short half-life. So the problem with the procaine is that you need a lot of it to continue working. So as you operate, you need to add and add and add and add, almost like every 10 minutes if you're operating under infiltrational anesthesia. But they're not toxic, so you can use a lot of it compared to amino amides. Amino amides, classic example, bupivacaine, predominantly metabolized in liver. Prilocaine can be metabolized in the kidneys. Metabolic rate differs between different drugs. The lidocaine metabolized more than bupivacaine, more than bupivacaine. Metabolites are usually excreted by kidneys. And patients with reduced hepatic and renal functions eliminate amino amides slower, and they are at higher risk of local anesthetic systemic toxicity. Let's talk about what can we add to the local anesthetic to improve the block, basically, and usually we're talking about the duration of action. We can add some epinephrine, adrenaline, which obviously will vasoconstrict. And common indication for that is peripheral nerve blocks, infiltration anesthesia. We add it to the epidural anesthetic solutions, and the common dosage is 3 to 5 micrograms per mil, or 1 in 200,000 or 1 in 400,000. In certain areas, like in dentistry, we use Citonest lidocaine with 1 in 80,000, which is quite concentrated. That's why a lot of people, when they go to the dentist, they said, I'm allergic to local anesthesia because my heart was racing when they injected local anesthetic into my gums, which is normally not because of the local anesthetic, but because of the high concentration of adrenaline. We can add opioids. Usually we do that for neuraxial block intrathecally. We can use preservative-free morphine in a dose of 100 to 200 micrograms. Fentanyl being used, sufentanil. We routinely use fentanyl with a concentration of 2 micrograms per mil in our epidural infusions. You can use opioids into peripheral blocks as well. We can use ketamine, that's been used, particularly intrathecally. And then clonidine was used quite a lot in the past with neuraxial blocks, peripheral nerve blocks, and epidural blocks. Although, as you know, clonidine causes sedation. The newer agents like dexamethasone or dexmedetomidine has been tried, and this is the research article comparing the efficacy of dexamethasone versus dexmedetomidine combined with the local anesthetics for the brachial plexus block. This was the meta-analysis and systematic review that was performed in 2022. And what have they found? They found that the results confirm that dexamethasone is the best adjunct to local anesthetic for brachial plexus blockade, enhancing the blocking effect, not dexmedetomidine. The more recent review, which was just published in May 2024 by Professor Eric Albrecht from Switzerland, compared intravenous versus perineural dexamethasone in order to assess which one prolongs analgesia after interscalene brachial plexus block. Again, they've done systematic review with meta-analysis. And what they found is that the duration of analgesia was 2 hours longer with perineural v intravenous dexamethasone. So if you added perineural, yes, it does work longer compared to intravenous. However, as perineural use is off-label and can lead to crystallization when co-injected with local anesthetic, the authors actually recommended intravenous administration rather than perineural administration, given that the limited increase in duration, only 2 hours, that was for the brachial plexus block, limited increase in duration of analgesia afforded by the perineural administration. So they reckon that for the sake of a couple more hours, it's not worth taking the risk. So if you're using regional anesthesia, give intravenous dexamethasone, it will still increase the duration of the block. It will still enhance the quality of the block, and it's easier to then just to add to the local anesthetic solution, risking the precipitation. Okay, what else can we add to local anesthetic? We can add glucose. And why do we want to do that? Because we want to make it hyperbaric or heavy. This is the Marcaine, which is obviously a commercial name of bupivacaine produced by AstraZeneca. And that is heavy Marcaine, as it's known by many of us. And it's basically a bupivacaine solution with added 80 milligrams glucose per mil of solution, which makes it hyperbaric. What does it do? How does it help us? It basically increases the baricity and enables us to control the height of the block. So if we put the head down, then the block will spread upwards. And for example, for cesarean section, we can reach the desired level of T4 a lot easier with the hyperbaric bupivacaine compared to the isobaric bupivacaine. But remember that you can play with it for about a maximum to 20 minutes. If you haven't achieved the block required in 20 minutes, then it's not going to work because it get fixated in the tissues already. So you need to play pretty much straight after you have delivered your heavy bupivacaine intrathecally. Okay, now we're switching the topic and we're going to talk about local anesthetic systemic toxicity. Okay, so what is the mechanism of the local anesthetic systemic toxicity? As we touched upon already, it's in the molecule basically of the local anesthetic. We have a lipophilic aromatic ring, which helps us to penetrate the cell of the membranes. We have hydrophilic amino group, which is the interaction with the protein, hence it gives it the duration of action, and the intermediate chain determines the potency, but also determines the toxicity. Um, what is the mechanism of cardiotoxicity? As we said before, because it works on all sorts of different channels, working on sodium channels, it will have an effect on conduction, so mainly on the bundle of His, but also it will decrease the membrane potential at rest, impairing the action potential conduction. It will prolong the PR interval, QRS interval, ST interval, and can cause re-entry tachycardias and bradyarrhythmias. Tachy and bradyarrhythmias. Working on potassium channels, it will also prolong the QT interval. As I mentioned before, it also works on calcium channels, on sodium calcium pump, reducing the calcium stores. Hence, it will decrease the myocardial contractility. The mechanism of neurotoxicity may consist of increasing concentration of local anesthetic that has an effect on cortical inhibitory pathways by blocking sodium channels and impairing inhibitory depolarization of neurons. That leads to excitation and seizures, and then with increasing concentration of local anesthetic, suppression of excitatory pathways, depressive phase with development of coma and respiratory arrest. What are the factors that influence in the development of the local anesthetics? There are three: local anesthetic properties, administration technique, and patient factors. Let's look at them in turn. Local anesthetic properties, some of them are vasoconstrictors, some better than the others, and the best one is cocaine. Also, there are differences in stereoisomerism of local anesthetics, for example, between bupivacaine and levobupivacaine, which is only one isomer, as you know, of bupivacaine. And adding adrenaline, epinephrine into the local anesthetic solution also takes an effect on development of local anesthetic systemic toxicity. As you can see, levobupivacaine is like half of bupivacaine. It's the left rotating isomer of bupivacaine, and all the good things are in that left part. Same with many other drugs, for example, like esketamine. Esketamine has all the good effects of ketamine, but none of the side effects of ketamine. Same with the levobupivacaine. Then we're also talking about this cardiovascular CNS ratio, and it's that ratio of a drug causing catastrophic cardiovascular collapse to drug dose causing seizures. So the lower the ratio, the more cardiotoxic drug is. So bupivacaine, for example, is 2, which is very low, and lidocaine is 7.1. So the higher this ratio is, the earlier the CNS toxicity will manifest before the cardiovascular abnormalities will be manifested, which means that if we can see the earlier signs, the CNS signs, then we can act quicker and we can start the treatment quicker. So for, again, comparing our best friends lidocaine and bupivacaine has a lower CV CNS ratio, hence the manifestation of the CNS symptoms will happen slower compared to lidocaine. So levobupivacaine and ropivacaine, their CNS cellular uptakes is lower, convulsive threshold is a lot higher, and they're 7 times weaker potassium channel blockers with reduced risk of QT interval prolongation and hence lower risk of arrhythmias. So all these newer drugs, levobupivacaine, ropivacaine, are safer than their parental drug, bupivacaine. So their ratio CV CNS higher than the in bupivacaine, and they have slower absorption than bupivacaine. So basically, the bupivacaine is the worst. Hence, we have in our trust a few years ago switched completely from bupivacaine to levobupivacaine for the sake of safety. So, and if you're injected levobupivacaine inadvertently intravenously, then the risk of developing LAST is a lot lower compared to bupivacaine. Administration technique. Obviously, if you inject it intravascularly, then LAST will develop a lot quicker. If you're exceeding maximum dose, which I will show you later on, then of course your patient will be at higher risk of developing local anesthetic systemic toxicity. And the speed of administration also matters. If you're just whacking it really quickly, and then the anesthetic can penetrate into the vessels easier. And if you are injecting very at a high pressure, then you're facing the risk of needle displacement that can then be moved intravascularly inadvertently. Excessive volume also matters. So don't exceed. I never really inject more than 20 mils into any type of block, and it's been shown that with non-anesthetist, the risk of the ratio of developing, the percentage of developing of LAST is higher compared to the trained anesthetist. These are the maximum doses recommended by local anesthetics, recommended by ASRA, American Society of Regional Anesthesia, and I also recommend that you calculate this dose based on lean body mass, not on total body mass, which in obese patients can be massive. And you can see that it's slightly different if you're injecting with and without epinephrine. Adrenaline, obviously, you can inject a lot more with adrenaline because it will reduce the absorption. All right, so let's move on. Plasma local anesthetic concentration and site of administration. We touched upon that already, and obviously it will be highest if you inject intravenously, then intratracheally, then intrapleurally, intercostally, and subcutaneous will be the least high if you inject it. Upper extremity blocks are more common than the lower extremity blocks. The local anesthetic toxicity, I mean. That's why it's recommended that you do your upper extremity blocks either awake or with some sedation. And it's kind of agreed that the lower extremity blocks can be done while the patient is asleep. It's more frequent local anesthetic toxicity with catheter compared to the single block, and LIA, local infiltrational anesthesia. During LIA, absorption is higher, for example, in hip replacement rather than the knee replacements. Okay, what are the patient factors? Age matters. Elderly, they have reduced clearance of local anesthetic due to reduced organ blood flow. The myelin sheaths are thinner, hence they have to go high sensitivity of the axons to the action of local anesthetic. So you would reduce local anesthetic doses in elderly by 10 to 20% for the same effect. Children, pregnancy also matters. Increased cell membrane permeability and decreased binding to local anesthetic. So you would use lower doses in pregnant as well. Patient factors continue. We have patient with hepatic failure, where the clearance is decreased of local anesthetics. So you would reduce dosage on average by 20 to 50% of initial dose. In heart failure, decreased clearance of local anesthetic due to decreased blood flow, reduced dose in severe congestive heart failure, and in renal failure, hyperdynamic blood circulation, dose should not be reduced except in terminal phase. Okay, if you think that liposomal, the newest drug, Exparel, the liposomal bupivacaine, will be any better, then it's not. IV administration is less safe than with a non-liposomal bupivacaine. The manufacturer recommends not to administer any other alkaline anesthetic within 20 minutes of liposomal bupivacaine administration. And the last presentation will be exactly the same with this liposomal bupivacaine, so don't treat it any different. Topical anesthesia for upper airway surgery, we use a lot of it, but remember the safe dose for topical anesthesia of lidocaine is 9 milligrams per kilogram. Intravenous local anesthesia or Beer's block, the recommended dose of lidocaine is 1 to 3 milligrams per kilogram. You have to use the double cuff. And the seizure has been described in doses of 1.4 milligrams per kilogram of lidocaine, prilocaine 4, bupivacaine 1.3. Although I said 1 to 3 milligrams per kilogram, but I wouldn't use more than 1 milligram per kilogram for intravenous regional anesthesia. And cardiac arrest has been described, noticed with lidocaine doses of 2.5 and bupivacaine of 2.6 milligram per kilogram. Okay. So we do not ever use bupivacaine for this type of anesthesia and mainly use lidocaine or prilocaine. But prilocaine you have to reduce to 600 milligrams maximum due to risk of developing methemoglobinemia. Okay, let's talk about clinical presentation of local anesthetic systemic toxicity. CNS toxicity is most common in 68 to 77% cases. 1/3 of cases start with CNS toxicity, followed by cardiovascular symptoms. About 20% are isolated cardiovascular symptoms only, so you will not have any pre-warning in terms of CNS toxicity, and it goes straight into the cardiovascular collapse. Delayed onset is known with the infusion of local anesthetic for a few days, and in about 40% is atypical presentation. CNS toxicity classically described as a biphasic process. Excitation process stages to start with tingling, circumoral numbness, ringing in the ears, slowed speech, tremors, dizziness, agitation, metallic taste, diplopia, all these sort of things. And then the CNS depression stage happens with seizures, loss of consciousness, and respiratory depression. Cardiovascular toxicity classically is described in 3 stages. First stage of hypertension and tachycardia, then second stage of myocardial depression and hypertension, and the terminal stage where you have massive peripheral vasodilation, hypertension with vasodilation, tachybradyarrhythmias, conduction disturbances, ventricular arrhythmias, and eventually asystole. Let's talk about the actual case that happened in 11th of May 2004. This is the picture from the newspaper. Epidural drug, death, mother was unlawfully killed. This is the case of a 30-year-old nurse from the Philippines who was having a baby in one of the hospitals in England. 45 minutes after delivery, she suddenly develops dizziness, loss of consciousness, seizures, and then 3 hours later she dies. And then they noticed that she had been given between 100 and 150 mils of bupivacaine intravenously instead of epidurally. So basically, somebody wrongly connected epidural infusion to her intravenous line. 6 years later, hospital admitted the mistake and was fined by this sum. Interestingly, before this case happened, there were 2 similar cases, and the measures were taken where they introduced a separate cupboard for local anesthetic, but then they moved into a new site, and these measures were not renewed. So this fatal case happened. This is the case from our hospital where Saptinon block was administered. for vitrectomy due to macular degeneration and laser surgery. It was a fairly healthy 60-year-old gentleman who was having retinal detachment, and 4 mils of 0.75% ropivacaine was used. The block was not quite to the anesthetist's satisfaction. They declared that to their surgical colleague, and he said, "Oh, don't worry, I will top it up with some lidocaine." So he kept topping it up for during surgery at the total dose of 20 mils by surgeon. They've noticed during the case increasing hypertension up to 220 over 100, and tachycardia was also present. Then suddenly this patient developed, in about 40 minutes or so into the procedure, respiratory arrest, loss of consciousness. They've been intubated, provided anthropic support, taken to CT scan, which revealed hemorrhagic brainstem stroke. So this could be the case of the systemic local anesthetic toxicity causing high blood pressure, pop vessel, and hemorrhagic stroke. Fatal outcome after 24 hours. So how often the last presents? If you inject massive dose intravenously, it will be less than 60 seconds when you will see all the symptoms that we described. It takes 1 to 5 minutes if you have a partial intravascular administration. After 15 minutes, administration of maximum single dose for peripheral regional anesthesia. So if you've done your brachial plexus block, observe this patient closely for 15 minutes for signs of local anesthetic toxicity. What would you do? What's the initial phase? You would stop introducing of local anesthetic. You would call for help. You'd provide the airway support with intubation if necessary, 100% oxygen. Hyperventilation may help to lower pH in metabolic acidosis. You obviously will secure the intravenous access, and you will try and control seizures using benzodiazepines or thiopentone. In case of cardiovascular arrest, you would start cardiopulmonary resuscitation, consider bypass if it's available in your hospital, and will give intravenous lipid emulsion that we will speak about later on. Without circulatory arrest, you would conventionally treat hypertension, bradycardia, tachyarrhythmias, and consider intravenous lipid emulsion. Okay, lipids, are they good? And why are they good? Because this gentleman called Guy Weinberg in Illinois University in 5 years at the turn of the century um, discovered that if you inject a high dose of bupivacaine into rats, then you will cause cardiac arrest. And if you start CPR without on lipid emulsion like here, then nothing can happen. But if you inject bupivacaine and then give lipid emulsion, then you will restore circulation a lot quickly. This is what he was experimenting with different substances, and finally found that lipid emulsion does exactly that. What are the proposed mechanism of intralipid action? It is understood that it diverts local anesthetic from highly perfused organs like heart and brain to detoxification organs like muscles and liver. It forms lipid volume in the bloodstream by diverting local anesthetic away from receptors. It increases intracellular calcium. Also, fatty acids prevent binding of local anesthetic to sodium channels in myocytes, improves cardiac output and blood pressure, enhancing the diversion effect. Righty-ho. So we have in the UK, we have AGBI safety guidelines on management of severe local anesthetic toxicity, and it tells you to give 20% lipid emulsion at the dose of 1.5 milligram per kilogram over 1 minute. And then after that, start infusion of lipid emulsion at the rate of 15 mils per kilogram per hour. And after 5 minutes, you can repeat this boluses twice and then basically double the dose. So if we look at the 70 kilogram, average 70 kilogram patient, then you would immediately give, it's just for easy calculation, you would give 100 mils and you will start infusion at 1000 mils an hour. After 5 minutes, if it didn't have an effect, then you will give another 100 and then another 100 and then double the dose of infusion to 2000 mils per hour, uh, up to a maximum dose of 240 mils of 20% intralipid. After successful treatment, what you need to do is to transfer to a unit with monitoring facilities, monitor for signs of pancreatitis because you just gave a lot of lipids. And in the UK, we report to the NPSA, this agency that monitors all the adverse drug effects. And we also lodge this case into the lipidrescue.org for all the cases. How can we prevent local anesthetic systemic toxicity? Obviously, we can now use ultrasound. And it's been shown that the dose for local anesthetic blocks has been reduced since the routine use of ultrasound. Use the test dose, always use the test dose, particularly if you're doing epidural infusion, because your catheter could have migrated intrathecally. And if you just use a massive dose, obviously you will achieve the total spinal, but your catheter could be migrated not into the CSF, but also intravascularly. Inject slowly, inject intermittently, 3 to 5 mils, stop, observe, give pauses between these portions. And if you use adrenaline, then you will quickly see the increased tachycardia. So we normally use 1 in 200,000. And in our country, for all the neuraxial and peripheral nerve blocks, we now use special syringes, special needles with something called NR fit connectors. So you cannot connect a normal syringe to the spinal needle, to the epidural needle, to any other block needle. Here they are. We have kits available, and this process started since in the late noughties there was a case of inadvertent vincristine injection intrathecally with the fatal outcome. So, and then since then, lots of manufacturers started to develop these different types of needles with NR-FIT connectors, just to distinguish anything that is going around the peripheral nerves intrathecally from those that is going intravenously. Right. So conclusion on this topic. Last is the rare but very, very dangerous clinical situation. Compliance with doses and rules of administrations of local anesthetic is very, very important. Those rules that I have spoken to you about already. Use ultrasound. That will show you that you're not injecting intravascularly, because if you are injecting intravascularly, you will see that the local anesthetic is not spreading around the nerve area but being taken away by bloodstream, and you will be suspicious. Remember that normally the signs of CNS toxicity appear first. So look for the signs of the CNS toxicity. If your patient tells you they've got circumoral numbness and tingling in their tongue and in their lips, be very careful, stop injecting. Remember, first stage of CNS toxicity is hypertension and tachycardia. If it's crashing blood pressure, bradycardia is the second stage, it could be too late. So treat hypertension, tachycardia very suspiciously, and have your 20% intralipid available in all clinical areas and know your doses. So 1.5 mils per kilogram as a first dose, 1,000 mils per hour. Um, okay, let's talk about principles of regional anesthesia under the ultrasound guidance. We're moving on, and what kind of methods do we have for detecting peripheral nerves? We have paresthesia, and when I started my anesthetic training in 1996, that's all we had. We were basically poking the nerves with a sharp needle and asking the patient where does he feel paresthesia, assuming that now we are in the region of ulnar nerves or nerve origin or radial nerve and so on, and then we were injecting accordingly. I'll show you why this is not a good practice. Methods based on superficial landmarks We use that a lot. Loss of resistance we use for epidural, for example. Then we used nerve stimulation for decades. And of course, we can see the nerves with the computer tomography, with magnetic resonance imaging, and lately with ultrasound, which is the most practical. What is the danger of paresthesia with regional blockade? It's been shown a high risk of complications where the paresthesia was deliberately induced with auxiliary block, and complications were 2.8% v 0.8%. All cases of radiculopathy after peripheral nerve blockade paresthesia during needle insertion in pain and injection were mainly due to paresthesia techniques. An intralumbar blockade increases the risk of neurological sequelae 13-fold in the presence of paresthesia. So when you're inserting your needle, if your patient experiences paresthesia and says, "I had a shooting pain down my right side or left side into the glute and into the leg," then don't go that direction. You could be touching one of the nerves. Right, peripheral nerve stimulators we use a lot in the past, and as you can see, we can uh, use different amplitude, different pulse width, different frequency. Normally, the frequency was set into 2 hertz and different impedance. And we would normally start with 1 milliamp approaching the nerve and uh, looking for the motor response. And if the motor response disappears, is still present at about 0.5, 0.3, then you're very close to the nerve. But then the motor response should stop once you are injecting around the nerve. If it didn't stop, you could be within the nerve. So you'll have to withdraw. But still, obviously, this is the blind technique, although better than the paresthesia. And what is the patient perception of using nerve stimulators? For patients, is actually block can be very, very unpleasant. Um, Although from anesthetic point of view, it could be excellent, particularly when they contract in muscle during nerve stimulation um, of the nerves of the broken limb. It could be quite painful and unpleasant for them. What are the other disadvantages? Cannot be used in combination with muscle relaxants. If you tube and paralyze somebody, you cannot use muscle nerve stimulator. Not possible to perform repeated blockades because you will not elicit any effect. The quality of the block performed a lot depending on the experience of the anesthetist. So it's very variable between different individuals. And nerve localization methods are blind, like I said before, and based on knowledge of anatomy, subjective, objective sensations arising from contact the needle with the nerve. And in the absence of visualization during the block, the numbness and complications increases a lot, like pneumothorax, nerve damage, and so on. At some point, there was this transdermal verification of the nerve trunks. There was like a little pen that you could just put on top of this skin over the, in this case, brachial plexus, and looking for the best location to insert your needle. So there's like a mapping of the nerve that was going on. It didn't really take off as good as compared to ultrasound. So the ultrasound was first introduced in 1994 for brachial plexus block, and then it took a long time to reach the adequate level of knowledge and ultrasound technology. Mind you, transdermal verification and neurostimulators now are advocated by a lot of original anesthesia enthusiasts in combination with ultrasound and in combination with the special devices that measure the pressure at injection. Uh, General provisions for all the blocks: you use the hand sterility and sterile injection site. We use a solution of chlorhexidine. Asepsis could be given by different ways. There are special devices that they use. You can just use the glove, or you can just use the opsite or other sterile dressings on the actual probe. You don't have to. If you're using a single shot, there is no evidence that you need to gown So normal hat, mask, and sterile gloves is sufficient. Ultrasound gel makes a lot of difference. Apply the ultrasound gel. You can see on the top the picture without gel and with the gel is a lot better. General principles: use the NR feed connector needles and use, if possible, echogenic needles. So the special needles designed for use with ultrasound. They are like this. They have this so-called golden nuggets there that will help the ultrasound to see the needle better. Right. Ultrasound is the form of basically a mechanical sound that travels through the conducting medium, body tissues, as a longitudinal wave. Right. The frequency of the ultrasound is above 20,000 or 20 kilohertz. Medical ultrasound commonly is 2.5 to 15 megahertz, the range. In comparison, our hearing, man's hearing, is 20 to 20,000 hertz. Okay, so it's a lot higher. That's why we don't hear it. Frequency is the speed divided by the wavelength, and the higher the frequency, the higher the resolution, but the lower the depth. Okay, so it's a compromise. And if you using different probes, then the probes can deliver a higher frequency and show you the better picture, but not very deep. So if you want to look deeper, then you need to reduce the frequency, which will increase the depth, but will reduce the resolution. So for examination of the abdominal organs, we use lower frequencies, but for superficial fractures like nerves, brachial plexus, and so on, we use high frequency. Hence, we can see better at the not such a massive depth. How is the image generated? Ultrasound image is generated when the pulse wave emitted from the transducer hits the structure and reflects it back and return to the transducer. That's how the transducer waits to receive the returning wave, or we call it echo, after each pulsed wave. That's why it's called echocardiography or echo something. It's the echo that is can bounce back from the tissues and reflects it back into the transducer. Transducer then transforms this echo, mechanical energy, into electrical signal and displays it on the screen. And it's this conversion of the sound of an echo to the electrical energy, which we call piezoelectric effect. First described by not anybody but Pierre Curie himself. There are many different ultrasounds probe available, as you can see on the screen, but for regional anesthesia, the main probe is linear. So use linear probe for majority of your blocks, unless they're deep blocks like lumbar plexus block. And the beam, remember that the beam is very, very thin. It's only 1 millimeter thick. And it's a two-dimensional image. What you see on the screen is two-dimensional, like in the book. Ultrasound tissue interaction. As the beam travels through the tissue layers, the amplitude of the original signal becomes attenuated as the depth of the penetration increases. So the bigger the depth, the more the signal, the weaker the signal, basically. And as this attenuation is due to many factors like absorption, reflection, scattering of the surfaces, and high frequency waves associated with attenuation, limiting the tissue penetration. So let's look at how different tissues are, what different tissues have an impact on attenuation. Blood, for example, the attenuation is if you're increasing the frequency, hence increasing the depth, decreasing the depth. With blood, it doesn't really matter. With liver, it matters a lot. With muscles, even more so. What can we compensate for attenuation? It is possible to compensate that using something called gain, and which is the degree of receiver of amplification. Okay. So when we're increasing the gain, it will amplify only the returning signal, but not the transmitting signal. Okay, only the echo will be amplified, and that increase of the overall gain will increase the brightness of the entire image, including the background noise. And on the machine, you can see number 6 here is the gain button. All you have to do is to turn this button if you want to increase the gain, the receiving signal, the echo, and you will start seeing structures better. And on lots of machines, there are three of this. On this machine, you can see three of them, and you can preferentially increase the echo on the top of the screen, on the middle of the screen, and on the bottom of the screen, depending on which part of the screen you want to see better. Okay, tissue echogenicity. When echo returns to the transducer, its amplitude is represented by the degree of brightness. This is what we call echogenicity of a dot, okay? And it's combination of these dots that give us the final image. And if the strong tissues like diaphragm, stones, bone, pericardium will be hyperachoic. This is the second one is hyperachoic. So this one, third image is hyperachoic. So it will look white, okay? And the weak signal will be hypoechoic, will be dark, okay? And these are solid organ. This could well be liver with the blood vessel inside. And anechoic is all fluid filled surfaces. Anechoic is completely black. If you see something black, this is normally a vessel. Okay. Different tissues. Veins are anechoic but compressible. Arteries are again anechoic, black, but pulsatile. That's how we distinguish between the two. Fat, hypoechoic with the irregular hyperechoic lines within it. Muscles, they are mixture of hyperechoic lines with hypoechoic tissue background because within muscles we have tendons. Tendons predominantly hyperechoic, predominantly white, and bones are plus hyperechoic with hypoechoic shadows. And nerves could be hyperechoic and hypoechoic with the rim around them. Let's have a look. Let's have a look. So nerves here, this is longitudinal nerve, okay, and this is medial nerve, which looks white, okay. And in brachial plexus, the nerves are actually black with rims around them, okay, with like that's what the nerves look like. So that's why always press a little bit with your probe, see if it's compressible. If it's compressible, it's the vessel. So how can we insert the needle? It could be in plane with a probe, or it could be out of plane. In plane, the entire length of the needle is visible, which is good. The more parallel of the needle is, the better the visualization. Although it's a lot more difficult to hold the needle directly under the transducer, and the longer the injection is potentially quite uncomfortable for the patient. And what are the problems associated with this approach? The longitudinal axis of the needle may be at an angle, hence it will disappear from the beam, and the needle path may not be displayed where the end of the needle is. So our biggest problem is to see the tip of the needle, and if you deviate from the beam, which remember is only 1 millimeter, then you will see the shaft of the needle, but not the end of the needle. So you need to be in parallel during quite a long path. Out of plane, you can see how the needle crosses over the beam. After the insertion, you may need to change the angle to find it. So you will see like a little dot. You will see only the tip of the needle with this approach. But it's kind of needle positions determined by soft tissue fascia movements, shorter distance to the nerve. It kind of simulates the original regional anesthesia. So it's a lot quicker to get to. But majority of anesthetists prefer in-plane technique, and position will be confirmed eventually by you injecting. Before that, you sometimes don't know quite don't know where you are with it, with this approach. Um, as I said before, interesting observation is that the further away the nerves are from the center, the more white, the more hyperechoic they become. And compare brachial plexus block. Here they are, black dots, look like vessels with the rims around them, compared to the femoral nerve, which is all quite hyperechoic, hence looks white. They're not necessarily round. They could be of different shapes. They could be triangle. They could be round. They could be completely flat nerve. So don't expect to see the round structure and think the nerve should be round. Okay. Um, Also remember that the sharper the injection angle, the poorer the visualization of the needle is. And this is at almost 0 degrees, 30 degrees, and 60 degrees. And people done studies on that, of course. And local anesthetic, when you look at it, try and achieve ideal distribution around the nerve, not just on one side of the nerve. So although this may look good, but it's not quite ideal. You want to go underneath this nerve and inject a little bit to kind of so the nerve is all surrounded by local anesthetic. This is when it's going to work nicely, your block, I mean. What are the advantages of ultrasound? Obviously, unlike with CT scan or MRI scan, there is no ionizing radiation. They're quite mobile. They're like laptops, so you can take them anywhere these days. It could even be a mobile phone with a screen that you can use as an ultrasound. You can connect the ultrasound probe to your mobile phone. Visualization of the nerves and adjacent structures, you will see vessels, you will see the pleura, hence you will not go to that tiger territory. And visualization of the effect of local anesthetic spread, you will see where the anesthetic is going, where you when you injecting it, unlike when we were using the nerve stimulators. So you will see the intravascular, intrapleural injection in real time. So hence, you'll have less complications. You will use less volumes of local anesthetic, hence, you will reduce the incidence of LAST. And it can be performed with muscle relaxants, so you can intubate, paralyze this patient, and still use the block. What are the disadvantages? It's costly, it needs training like anything, and of course, in the obese patient, everything is trickier, including poor visualization of the structures. Um, what are the general principles of peripheral nerve blockade using ultrasound? The quality of image depends on the quality of the apparatus. The better the apparatus, the better the image, the transducers, and of course, like with everything, by the experience of the anesthetist. So do a lot of blocks, and you'll get better. Sterility is important. Correct patient position is important. You need to have a good sort of position of your patient and yourself when you need to be comfortable when you're basically when you're performing. If you say, for example, if you're delivering block on the left leg, put your machine on the other side of the trolley along the right side, right leg of that patient, and so you look directly on the screen rather than to look to the side or back. Combination with the nerve stimulation is possible and is encouraged, and it's necessary to visualize not just the progression of the needle, but also the spread of the local anesthetic. So once you've found where you are, do not take the probe off and see where your anesthetic is going into. You may adjust the position of the needle. And our last topic is the regional anesthesia and acute compartment syndrome. This is again the regional anesthesia. These are the guidelines delivered by our association in Great Britain. Regional anesthesia for lower leg trauma and the risk of acute compartmental syndrome is because of this lower leg that is the most widespread in terms of development of the acute compartment syndrome. Right, so let's look at this syndrome. What's the definition of it? It's the condition which is increased pressure within the enclosed area of the body that disrupts the blood flow and tissue function in that particular area. And what is the most common sites is tibia. Okay, tibial fracture is the most frequent occurring. Forearm sometimes, occasionally in the shoulder, thigh, buttock, foot, and hand, and occasionally in skull, eye, spine, abdomen, thorax. It could be abdominal compartment syndrome, but it's very rare. It's a lot rarer than the tibial. Um, what's the frequency? It's 3.1 per 100,000 of cases. And fractures account almost 70% of combatant syndrome. Up to 40% are tibial. 4 to 5% of tibial fractures results in acute combatant syndrome. Males are a lot higher incidence because males do have more fractures. And risk factors include intraosseous access for infusion, open fracture, intramedullary nailing, like it's on this picture, anticoagulation at the same time, high energy penetration trauma, vascular injury, burns, use of tourniquet, hemophilia. What are the causes? There could be orthopedic fractures, soft tissue crash, soft tissues, ischemia, reperfusion, arterial, venous injuries, and iatrogenic causes, iatrogenic drug or fluid extravasation, position on the table, large diameter cannula with, for example, intra-aortic balloon pulsation, pneumatic anti-shock garments, and other causes, recreational drugs, prolonged immobility results in limb ischemia. Classic thing when somebody is drunk is lying on one side overnight, that can cause combatant syndrome, electrocution, sepsis, DIC. What's the pathophysiology? Is when muscles, nerves, and blood vessels lie in those compartments, and after injury, the pressure in these areas increases, reducing perfusion and leading to localized tissue ischemia. And as the ischemic damage of tissues and membranes initiates trafficking of that fluid across the muscle and capillary membranes with subsequent increase in tissue pressure. And then this leads in turn in obstruction of venous outflow and increase in venous pressure, which is normally 4 to 7 millimeters of mercury. And then subsequent increase in capillary pressure causes vicious circle of increased transudation, marked tissue edema, and increased pressure. And remember that needs to be acted quickly because the irreversible changes will occur in 4 hours. How we diagnose this? Pain is the main symptom, which is why some surgeons say that they don't want us to block tibial fractures, for example. Paresthesia, loss of two-point discrimination in the projection of the nerves. Increased pain with passive extension of fingers or toes. Cold limb, pale limb, paralysis, absence of pulse. But remember, the last two, cold limb, paralysis, pale limb, absence of pulse, are late symptoms. So we should be looking at pain, paresthesia, and increased pain with passive extension of fingers. This is the observation chart. This is what I mean by passive extension of fingers. And it's observation that makes diagnosis of this compartment syndrome quicker. Also, we can measure intercompartmental pressure with single or continuous pressure monitoring. And it needs to be done in high-risk patients with comorbidities like hemophilia, like vascular injuries, and so on, like open fractures. And as little evidence exists that the continuous monitoring reduces the risk of this syndrome compared with the symptom monitoring. So there is a diagnostic algorithm that's been developed for the suspected compartment syndrome, where your patient is not alert. For example, you would measure the compartmental pressure, and if it's more than 30 millimeters of mercury, then you would consider fasciotomy. So the difference of 30 millimeters between measured pressure and mean arterial pressure is the indication for fasciotomy. So according to the literature, deep neuraxial or peripheral nerve blockade may be associated with a delayed diagnosis of this syndrome when extended to the postoperative period. But there is no convincing evidence that the use of single or continuous peripheral nerve blockade in low concentration of local anesthetics mask the symptoms of acute compartmental syndrome and delays the diagnosis. So the trick here is to use it, but in a low concentration. Okay, so there is some degree of discomfort will be present if that syndrome starts available. So do not aim for dense blocks, basically. And in surgical opinion, they say, these two professors said, there is no dispute when there is simple solution: monitoring. It's the monitoring that is important. And this is the article, the graph from that article, where compartmental pressure monitoring has higher sensitivity and higher specificity. So measure the pressure, you will not miss this syndrome, and measure the symptoms. And the treatment is the fasciotomy if that happens. Right. Let's finish with summarizing what will be the good rules of performing regional anesthesia. We're not talking about any particular blocks today, but this is not our last webinar. We may talk about this later. If you like my presentation, I'll tell you what we are planning to do later on. But the good rules of regional anesthesia consist of performing the block only in the best interest of the patient. You're doing it for the patient, not because you can, because this patient will benefit from this particular block. You need to have a good knowledge of anatomy, despite the fact that you now have your ultrasound probe. So you need to know what you're going to see on that picture. You need to master the technique and knowledge of your equipment. You need to still know the anatomy. So if you put the ultrasound probe below the clavicle or above the clavicle, you need to know what the structures are underneath there. Where is my clavicle? Where is my brachial plexus block? Where are my vessels? What vessels are they? What is the normal alignment? And you look at it and you do it again and again and again. Discuss the upcoming block with the surgeon. Tell them you're going to do the block, and discuss your doses between yourself and the surgeon, because the surgeon, particularly for the shoulder surgery, would like to use local anesthetic with adrenaline as well for his ports so it bleeds less. Discuss with the patient, discuss the possible complications, the side effect, tell them about the numbness, tell them about the tingling, tell them about the heavy arm, for example, tell them about inadvertent intravenous administration, and warn them about how they're going to feel and what are the possible complications and side effects. Ensure appropriate intravenous access and monitoring is applied. Do not treat regional anesthesia any different from GA. Same standards apply. They still need all the same monitoring for regional anesthesia. Aspirate and use fractional dose administration. Aspirate frequently, after 3 to 5 mils. Maintain documentation and keep track of it. Use the form. This is example. This is the regional anesthesia record recommended by the Irish Society of Regional Anesthesia. Dated. Name the procedure. Name the block. Um, Document that you have explained the procedure to the patient, that you obtained the consent, that you put the intravenous access, you considered anticoagulation or coagulation, you have performed stop before you block, you didn't put the block on the wrong side, you have been sterile, document that. Which needle have you used? Have you used ultrasound? Have you used nerve stimulator? Was it a loss of resistance? Did you perform the injection with a low pressure? Did you put the catheter at which length? What local anesthetic and what percentage have you used? And what was the outcome? Have you assessed the block? Was it satisfactory block? If not, what have you done to enhance the block, or add something to that block, like local anesthetic or a lower block? If you're one of the nerves for a brachial plexus block didn't work, did you went down the arm and block one of the nerves that you have missed? Be prepared to complications and know what you're going to do if complications occur. Be prepared to apply another plan. If your block didn't work, what you're going to do? How are you going to convert it to what? You need to discuss this plan with your assistants and with the surgeons. Don't be discouraged if the block doesn't work. Even in the best hands, sometimes it doesn't work, but keep doing it. The more you do, as one colleague said, the more I practice, the luckier I get. Don't give up, keep learning. What are the complications of regional anesthesia? They are nerve related, nerve damage related, damage to other tissues around it, vascular punctures, inflammation, and infection. So warn your patient about the possible nerve damage. Doesn't happen very often. Damage to the other tissues. It could be sore, particularly if injecting the muscle. Vascular puncture may have a problem with the last local anesthetic toxicity, and infection is the side effect of anything that we do in medicine. Um, Anesthetic related damage is this toxicity, as we saw, neurotoxicity, which could be long term, myotoxicity, and methemoglobinemia. And also, do not blame the apparatus. Like the famous Alan Winnie said, it's not the prick at the distal end of the needle that does the damage, it's the prick at the mm, other side of the needle that does the damage. Uh, Optimal use of local anesthetics for regional anesthesia requires a good understanding of the patient's individual clinical situation, location, intensity, and duration of regional anesthesia, and analgesia required, anatomical factors, proper drug selection doses, repeating assessment of clinical effects, and administration. Pulmonary complications, for some blocks like supraclavicular blocks, it's pneumothorax, and so you check with ultrasound these days very quickly. And for interscalene block is the phrenic nerve paralysis. So do not ever do that block on both sides. So this is the picture of a phrenic nerve paralysis. The diaphragm there on the right side is a lot higher. So if you've done it bilaterally, then obviously you will compromise the breathing of that patient. And here's some references for you for the talk that I've given and the intralipid references in particular. Right. Finishing off, what are my take home messages for you? There are two groups of local anesthetics, amide and ester local anesthetics. The properties of the local anesthetics is pKa, lipid solubility, and protein binding. That's all you need to remember from pharmacology point of view. Treatment of the local anesthetics, intralipid. Just remember, intralipid. Do you have it in the fridge in your hospital? Intralipid. Ultrasound is the major 21st century advance for regional anesthesia. Use ultrasound for all the blocks that you perform. Acute compartmental syndrome, mainly for the below knee fractures. Regional anesthesia, if you use it, use local concentration, monitor, and if suspicious, perform fasciectomy. Monitor with symptoms, monitor with pressure measuring devices. Thank you very much for your attention. I am thankful for a couple of my colleagues who kindly allowed me to use some of their slides. We spoke about basic principles of regional anesthesia. With you was Andrei Varvinskiy, consultant anesthetist from Torbay Hospital in the UK. For those of you who are preparing for the European exam in anesthesia and intensive care, I recommend the book that we have co-authored with Maria Zarafa and Sue Hill, How to Pass the Headache, which is available on Amazon and on all good bookstores. The original publisher is Oxford University Press. Also, I would recommend you my own YouTube channel, which now has about 2,000 subscribers with 75 different videos, including lots of videos on regional anesthesia.
In the middle of the screen, you can see a sciatic nerve which merged together, two nerves merged together, common peroneal and tibial nerve. So it's my needle coming from the left. I'm going underneath the nerve first, and then aspirate. Going to inject in a minute. There it is. You can see that actually the two nerves are splitting when you're injecting. So I want to inject about half of my local anesthetic under, and then I'm going to withdraw the needle redirect it and go above it, above the nerve, there it is. And then again, aspirate and inject, so you can see how there are two nerves separating within one sheath. Lovely, well done, thank you.
So that was the sciatic nerve block performed in one of the theaters where I work, and you will see a lot of videos like this on my YouTube channel. So have a look, Dr. Varvinskiy Anesthesia Education. Subscribe, like, watch, comment, whatever you like. But finishing off, if you like my presentation, then with MedVoice, with the help of MedVoice, we are planning regional anesthesia course for you, where I will be accompanied by my colleague from Oxford University, Svetlana Galitzin, and we have planned a 2-day course for you. So on day one, we will do an introduction in 5 minutes. Then we'll speak about the ABCDE of awake regional anesthesia, selected abdominal blocks like tab block, rectal sheath block, and other blocks, ultrasound assisted neuraxial blocks, selected chest blocks, rectus spinae, PEX 1, PEX 2, serratus anterior plain block, and femoral nerve block and fascia iliaca block. And on day 2, we will present to you adductor canal block, popliteal sciatic nerve block, foot and ankle blocks, selected upper limb blocks above the clavicle, and selected upper limb blocks below the clavicle. So watch the space. MedVoice will be in touch with you and advertise our course, which we're planning in about a couple of months at the end of September. It will be paid for, but it's not going to break your budget. It's not going to be very expensive. Trust me. So thank you very much for your attention today and listening to me. And if you have any questions, I'll be happy to answer later on.